Thank you, the organizing committee, the chairs, and the moderator. Thank you so much for this opportunity. I think I'll be talking about a subject that's a little different from the procedures and the protocols that we're following. It's more to emphasize the importance of a particular test that needs to be done, especially in cataract surgery. And the reason the cataract surgery is in focus is because that seems to be the highest priority as of now in terms of the surgical numbers. So I'll just go through what actually is happening. Normally, the cataract surgery focuses on the visual outcome, which has become excellent these days because of the evolving techniques and the technology. That undoubtedly, people have surpassed their own outcomes, and it has been the outcomes have changed, but the complications haven't changed much in terms of the endophthalmitis. And the rates have come down, but still it's being the one of the most dreaded complication, that is endophthalmitis. And we all know that NLD obstruction is one of the well-established risk factor for post-operative endophthalmitis. And of course, we've all shifted to use of povidone iodine, which has been effective for surface clearance, but it doesn't really help in the nasolacrimal duct clearance in terms of organisms. So it is imperative for us to keep the NLDO clear, which means we need to do the proper testing in order to perform the surgery. So let's look at what are the tests that are available as of now for confirming the occlusion in the lacrimal passage. Now, Rho plus is one, which is the regurgitation on pressure over the lacrimal sac. Syringing with saline has been used. Fluorescein dye disappearance test, especially in this particular era, we've started doing a lot of fluorescein dye disappearance test. Microreflex test, nasal endoscopy, contrast dactyocystography. Then we've also used imaging alongside of scintigraphy. Yeah. Now let's look at the downsides. Jones 1 and 2 and the dye disappearance test, there is an inability to estimate the level of obstruction. CT and MRI, particularly in craniofacial deformities, or when there is an injury and when there is a suspicion of neoplasia. The MCDG, definitely very useful. It's better than syringing, but the access and the economic constraints prevent us from doing this as a routine procedure prior to cataract surgery. We're not talking small numbers. We are all talking about hundreds and millions of cataract surgery. So we should keep the economic constraints in our mind. So regurgitation is definitely a non-invasive procedure with minimal patient discomfort, and it's easy to perform in the outpatient setting by all, either the ophthalmologist or the technicians, whoever is present there. Syringing is an invasive procedure, and from a survey by Akshay, we all know that it was a very well conducted survey. 60% of them felt that Rho plus was adequate for cataract surgeries, that is prior to cataract surgeries. This was done in 2015. But unfortunately, 30% felt the need to do a routine syringing. But those who have responded for wanting to do just Rho plus have not really provided any reasons for why they did not prefer syringing. And this was not within the purview of the survey as well. So I think that's another aspect that needs to be dealt separately. So the Rho plus test results are usually positive only in infected lacrimal duct obstruction with purulent material in the sac. So checking for NLD patency by Rho plus alone has its advantages. The sensitivity of this test was not found to be sufficiently high enough to rule out a NLD obstruction. So this has to be borne in mind. Now, in a study conducted in 8,000 and odd patients without any history of epiphora or any other lacrimal disorders, these were patients who were scheduled to undergo cataract surgery, where syringing was considered as a reference standard for detecting the obstruction in our study. So the ophthalmologist checked for regurgitation, assuming that they have full knowledge about the Rho plus test, and this is what has been universally accepted, and AIO's guidelines to spell it out very clearly that it has to be done by ophthalmologists. So reflux of fluid, mucoid or purulent from the puncta was noted, and mucoid or purulent regurgitation from either or one of the puncta during Rho plus was considered to be positive for NLD obstruction. Now, syringing was carried out by a trained ophthalmic technician, and regurgitation of, I think it was spelled out very clearly by the previous speaker. We knew where the NLD obstruction was, especially when there was a common canalicular obstruction or the same canalicular obstruction, or when there was an atonic sac. There is a point to be noted. The fluid passes off very clearly into the nasopharynx, but there was a swelling noted in the atonic sac. So this also was very clearly depicted in the syringing. Okay, so all of these are identified. One, the NLD obstruction was well identified. The common canalicular obstruction was well identified. The canalicular obstruction was identified, and an atonic sac was also identified using syringing. So in the 8,369 eyes, 61 patients with positive Rho plus and NLDO on syringing were diagnosed as chronic dacryocystitis. That was very clear. In 20 patients with positive Rho plus test, syringing test reported to have patent NLD. This was also very clear. So this showed that the patients had an atonic lacrimal sac. 51 patients with a negative Rho plus and NLD not patent with clear fluid through the opposite punctum with a hard stop are diagnosed as chronic dacryocystitis. 28 patients with a negative Rho plus and NLD patent with clear fluid through the opposite punctum with a soft stop was diagnosed as common canalicular obstruction. So the Rho plus test had a low sensitivity and a high specificity of detecting NLDO. So this was a paper which brought all of us to the point that we need not do syringing. A paper by Dr. Thomas et al., a famous ophthalmologist, way back in 1997, evaluated the sensitivity and specificity of Rho plus as a screening test for chronic dacryocystitis and compared it to syringing in 621 consecutive patients who needed syringing for various reasons. Out of the 621, only 318 patients were scheduled for cataract surgery. Please note this point. And authors reported a moderate sensitivity and specificity of Rho plus of 85.7% and 99%. They concluded that in view of the opportunity cost, please note, when Rho plus is negative, preoperative syringing in cataract is perhaps unnecessary. So we, on the contrary, found a much lower sensitivity of Rho plus, that is 54.46%, with the highest possible sensitivity being 63.9% in 95% of the cases. A diagnostic test with a low sensitivity will have a high level of false negative rate, meaning that when Rho plus was negative, the patient may be misclassified as not having NLDO in 45.53% of the patients that have obstruction. So we had a high specificity of 99.76%, which was very similar to the study of by Thomas et al. A high specificity of a screening test indicates that if Rho plus is positive, chronic dacryocystitis is almost definitely present. There's no doubt about this. But in practice, especially prior to an intraocular surgery, specificity cannot be taken into consideration in isolation. So a positive predictive value and a negative predictive value are more appropriate. So the PPV in our study was 75.31%. The NPV was 99.38, which was similar to the analysis of cataract surgery patients without lacrimal complaints, where the positive predictive value was 75% and negative predictive value was 99.5% in a study by Thomas et al. So there was no difference there. But when Rho plus is positive in these cataract surgery patients, there's only 75.31% probability that the patient has been correctly identified as having an LDO. The prevalence of chronic dacryocystitis in our study was 1.35%, whereas in the study by Thomas et al. Was around 6.6%, probably because of the fact that he included patients with complaints of epiphora, corneal ulcers, and routine cataracts, whereas in our study it was exclusively cataract patients, those undergoing cataract surgeries. So even though the NPV is high, as a consequences of missing out on true positives, there is a possibility of developing postoperative endophthalmitis, which is well known and well established. So we recommend routine preoperative syringing along with Rho Plus in cataract surgery patients, or in fact in all intraocular surgeries. But since this is purely a cataract session, I would like to emphasize that it has to be done prior to cataract surgery. Syringing might indicate NLD in cases of atonic sac where Rho Plus is positive, but major advantage here is the site of obstruction, which will help us to define and refine the treatment planning. Rho Plus and syringing together may be made as a routine preoperative diagnostic test before cataract surgery. So Rho Plus alone had a very low sensitivity and low positive predictive value in detecting NLDO prior to cataract surgery. Syringing improves diagnostic accuracy and aids in the treatment strategy after diagnosing the NLDO. Rho Plus and syringing in every patient should be part of the routine. Please remember, every patient prior to cataract surgery must undergo SAC syringing to reduce postoperative endophthalmitis. So this has to be included in our tests.